Now, I think we better move up.
Yes, we will. And we'll go up to the metacarpals. And what we're going to do is, therefore, we're going to look at the technique that are grouped as for bones that are adjacent long bones.
Yes.
Okay. And so we're going to take the example of having a pain with a patient who grips and has some pain on the dorsum of the wrist, a little bit more on the medial aspect. You've had a patient like that in the past?
Yep.
Okay.
You said the dorsum of the wrist.
Dorsum of the hand,
You
sorry.
meant the interstitial space between those long
That's
bones.
exactly what I meant.
I'll see that he gets it right.
Because you're so experienced that you picked that up right away.
All right. You've got long bones here, and I'm still... Mobilisations for movement are, for me, still in their infancy. I have a lady comes in, and she had fractured the shaft of her 5th metacarpal. And some weeks later...
Was she a karate type of person?
No, she was a normal person.
Oh, okay.
Anyway, she'd fractured that, and it had healed, and she had pain every time she gripped along that space between the 5th and 4th metacarpals. Driving the car was painful. She gripped anything, it was painful. So she comes to see me, and I thought, what can I do with her? How can I reposition her bones? Now, in the case of this woman, proximally on that metacarpal, I lifted it because when she broke her hand, it had smashed down like that. Isn't it conceivable, if you come up with this positional fault theory, that that articulation at the proximal end of that bone was perhaps a little out of place? And on lifting the shaft of that up, she had no pain.
That looks like it would be easy for her to do an accomplishment.
Yes, but don't tell them that.
Oh, of course. Okay. So would you show me the mobilization on me, what you're talking about?
Give me this hand. It's going to show to the camera.
All right.
Here we are. Here's the shaft of the bone.
Yes.
I fixate the adjacent base of the metacarpal.
The base of 4.
Yes, base of 4, and lifted 5 up.
Lifted 5 up.
When I did that, I asked her to grip, and she's got no pain.
I see. Okay. And then you just performed the sufficient repetitions.
Yes. Good,
How do you get overpressure for that?
Good question. You
just
can't
have
when you're
them-
gripping.
you
You
just
just
have
have
them
them grip
work
harder.
harder. Yeah,
You just have them work harder. Good point.
Okay.
And the other thing, of course, what I did with her, I wasn't silly. I taped that up and across obliquely.
Okay.
And she went out, and it was just quite miraculous. She just gone.
So in a nutshell, then, with adjacent long bones, what we're going to do is we're going to lift or lower on their neighboring bone to change the articulation.
That's right.
And whether you have to push more distally or more proximally, that's going to be...
Some joints you deal with distally, you're quite right, and the others proximally. Depends where the pain is.
And when you're taping, is there anything you need to be cautious about?
Yes, you're not silly. No, if you tape the metacarpal proximally, there's no problem. But if you had a problem between the space here, between the shafts of the 2nd and 3rd metacarpals distally, and lifting this this head up on this takes the pain away, you might say, right, I'll tape it up. And I did this only once on a patient. I taped it up and wrapped the tape around her hand, which in fact squeezed rather horribly these bones together, like people squeezing your hand. Oh, they hurt you. And she came back after leaving my rooms half an hour later with swelling and horrible pain. And I had made her worse, not because I'd made a correction, but I just got that area, which was painful anyway, and compressed it. So, if you want to tape it up, make the tape lie obliquely, so there's no compression of those long bones.
Very good, very good. So now we've covered the techniques for hinge-type joints or freely mobile joints.
Whether it's radius and ulnar, tib and fib.
And then adjacent long bones apply to the bones that you just discussed, the radius and the ulna, both ends, and the tibia and the fibula. That's excellent. And of course, it'll apply in the feet as well, to the metatarsals. Brian, would you now take us through the adjacent long bones in the metacarpals, please?
My pleasure. Now, we've spoken of positional faults as being the basis or the reason that mobilisations with movement work. With these long bones, these metacarpals, sometimes one is positioned up or down on its neighbour. And on occasions, you can visibly see this. When they make a fist, you can see these heads, the heads of the metatarsals, and sometimes one's up much higher when compared with the other side. Yeah. Mm-hmm. And you say, gosh, that's sticking up, it shouldn't be. Or the other way around, this is up. Mm-hmm. So you're suspicious straight away. And if you look at the other hand sometimes, you can see it. Mm-hmm. One hand, you can see the relationship of each metacarpal head, and then you look at this and say, that's up.
Yes.
But in any case, if the pain is distal between the shafts of the bones, lift one head up on its neighbour and get them to repeat the offending motion, which is always gripping, with a hand, and you've got an involvement between the metacarpals. Now, Jules will grip, and if she's got no pain, then we know that's the direction. If she's got pain, then we go in the opposite direction. She grips again.
Could you show me the same mobilization on 4 and 5?
Yes. Well, now on 4 and 5, you can do the same distally, but quite often also consider proximally. But you consider proximally if the pain is proximal. So if someone's got pain between the shafts of the 4th and 5th metacarpals, you grip with the base of the 4th, you grip with
in other words, your fingers, can I see the palm of her hand?
Yes,
your fingers are
that finger's
on 4.
right on the base.
On number 4. Okay.
On top, I'm on number 5.
That's 5. Okay.
I will elevate it and get the patient to grip. Or I will take it down in flexion direction.
Okay.
One will be painful, one will not.
In that case, elevation would be a posterior direction, and depression or pushing it down
ventral
would be...
direction.
Yeah, a ventral direction. Okay.
That's right.
All right.
Now, if these techniques are successful, you can use tape.
Okay. I've got some tape.
Good. Now, let's start distally with the tape. Let's presume that raising the head of the second metacarpal up causes pain. Locate underneath on the head of that metacarpal and take the tape obliquely across the hand. If you were to lift that head up and tape it straight across, transversely across, you have now compressed those bones, as people do when they shake your hands with... Make sure you don't squeeze those bones together.
Right. That'll cause a problem. Hey?
Yeah.
Well, now that looks pretty good. Could we just show that?
Yep.
Make sure that you can see the palm. It's just lifting up on the index MCP or number 2, and then we're pulling down actually the metacarpal, not the MCP, but pulling that up and obliquely coming across.
Give me another bit of tape and I'll show you something.
Yes.
Thank you.
That one should stick.
Yeah. Proximally, you haven't got the same problem with compressing the bones because these bones are already adjacent and touching. But still have some translation, some obliquity when you pull the tape across. So let me reposition. Julie, can you take it across obliquely? Yep.
And once I'll just point out, if you put your hands in position, your thumb is over 5 and your fingers are on 4. And if you could turn your hand over, then it's coming back here rather than coming across.
That's right, not in that direction. That's
The other thing that I might notice as you were doing this is that Julie had her hand a little bit tensed up a little bit. And sometimes what I'll find with my patients is that unless I have the patient, when they're pulling on the tape, they tend to tense up both sides. So if I can have them consciously relax this hand, we sometimes get a better result. But the result is always pain-free gripping.